Good morning, everyone. Thank you so much for joining us. This is the last day of the conference, but it's been a great time. We've been working on this for the last 16 months, and it's just wonderful to have you all here from different parts of the world. And of course, to have our wonderful plenary speakers. They're extremely, incredibly accomplished and passionate speakers who've made a difference in the world. And I'm so excited to bring them here. But before we introduce them and you get to the real meat of the closing plenary, I would be remiss if I didn't thank a lot of people who've helped us put this together. I'd like to thank our sponsors who've supported this and who've been around to help us put this together. Herman Miller, HKS, Macmillan, Paston Smith, and Leo A. Daly. And of course, my wonderful team. It's such a joy for us to close this conference on such a high note. Dina Battisto, where is she? I don't know. And B.D. Wortham-Galvin, these are my partners in crime. We've put this all together over the last 16 months. And Lynn McCracken, who you've all interacted with at the registration desk, he's a complete gem. And I'm so glad he's on my team. And of course, Jenny Ruggieri, Lindsay McKinn, and Amy Coley. I also want to thank the EDRA board for all their support through these months and giving us the guidance. When we started this, we had no idea what we have to do. Along the way, we've learned a lot. And hopefully we can pass it on to future EDRA local committee members. There's a lot of lessons learned, and it's a great community to be a part of. And of course, my student volunteers, they are amazing. Sarah, please stand up. She has been on this project right from the beginning. And Hadley, I don't know if she's in the room, they might be running around somewhere. And Taylor and Isabel, Swati, Meena, Devi, Monica, thank you guys. You have been amazing and you continue to be amazing. I'm glad you're part of my team. And of course, the larger team, we have many others who've been there on the ground, making sure everything goes well and that you have a wonderful experience. So if you see them, do thank them because they've done all the work. They've made it all happen. And of course, the School of Architecture and the College of Architecture, Arts and Humanities at Clemson, they've been really supportive of this idea. They've provided us support, funding for the students to be graduate assistants, and just everybody from the photographers who've been at this event, from the people in accounts, from the people in all different levels who've made it all successful and helped us do what we need to do. And with that, I'm going to hand it over to B.D. Wortham-Galvin, and she will introduce our highly accomplished and wonderful closing plenary speakers.
Thanks, everyone. This closing plenary, in some ways, the conversation began yesterday with our keynote on the issue of disparities in health outcomes and the design of the physical environment, right? In this case, the conversation was about housing and redlining. We're going to continue that conversation in disparities in health outcomes as we situate it with design with these three amazing women that we are so excited to have here today. I'm going to introduce all three of them now because then we want to have them do their presentation so that we leave plenty of time for a great discussion afterwards. Our first speaker is Dr. Debarati Majumdar Narayan, and she is an officer with the Health Impact Project, a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trusts that encourages state, local, and national organizations to consider health in decisions across sectors. Dr. Narayan leads research efforts and provides strategic guidance to community-based initiatives designed to equitably improve health outcomes. She's also an adjunct at the University of Maryland School of Architecture, Planning, and Preservation, teaching environmental psychology. And I keep stumbling over your name, Mimi, because I think of you as Mimi. I apologize for that. Our next speaker, situated on the far end of the table, is Dr. Rupa Valdez, an associate professor in public health sciences, as well as jointly appointed in engineering systems and environment at the University of Virginia. Her research focuses on understanding and designing solutions to support the ways in which people manage health at home and in the community. This work encompasses participatory and co-design approaches and attends to the ways in which the social networks, physical environment, community resources, and information technology shape patient experiences. She is also founder and president of the Blue Trunk Foundation. And then our final speaker sitting in the middle is Dr. Lynn Paxson. Many of you in EDRA know her very well, an emeritus university professor and professor in architecture at Iowa State University. Her teaching and research reflect an integrative interdisciplinary approach and focuses on people and spaces that are often considered marginal. A member of the American Indian Council of Architects and Engineers, and a Sequoia Fellow of the American Indian Science and Engineering Society, Dr. Paxson is also an affiliate of the Indigenous Design and Planning Institute at the University of New Mexico, where she is working to develop a national exhibition of contemporary Indigenous architecture. With that, I'd like you to welcome our first speaker, Mimi.
Good morning, everybody. My name, as you heard, is Debarati Majumdar Narayan, but I go by Mimi. Oh, yep, there we go. Thank you. So I'm a program officer at the Health Impact Project, which is a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trust. If you listen to NPR, you probably have heard those names before. And they are sort of large nonprofits, both of them, and a foundation. So I'll share more on what we do at the Health Impact Project in a little bit. I am an architect and a planner and environmental designer by training, but have been working at the intersection of health and the built environment for many years, many more than I care to admit. This is my 19th EDRA, if that gives you any kind of context. I'm also faculty at the School of Architecture and Planning at UMD, as BD said. But I want to start today by first acknowledging that we are standing here on borrowed ancestral land in Greenville, where the Salagwetei, or Eastern Cherokee, and Miccosukee once honored, served, and protected this land and celebrated their traditions. So I always start with land acknowledgement, and we are talking about place, so that's where we're starting. Okay, so just a quick look at, oh, yeah, okay, at sort of where we're going today and what I'll be touching on. But I will say, as environmental design researchers, right, we understand that where people live, work, and play impacts our health, including the physical, mental, and social well-being of our population. So built environment design can support connectivity and facilitate active transportation, such as walking and biking. We can promote social cohesion and generate social capital. But design, of course, we know, can also isolate communities, limit access to resources, including access to food, jobs, healthcare, and education. Now, these social and economic political factors like segregation, poverty, political participation, or the ability to do so, living and working conditions like housing, access to healthy foods and jobs, public services and infrastructure like transportation, community centers, schools, parks. All of that collectively is known as the social determinants of health, if you are not familiar with that term. But essentially, the social determinants of health drive our health outcomes. So that's how we, or I, in our work, define health and well-being. So it's a very broad term of how health is defined. Now, we know that the distribution of and access to these resources or services for education, transportation, whatever it may be, can really be different in different communities, right? So even across a city or a region, it can be different. And so therefore, that means there's a huge impact on health outcomes in different places. Here's a quick example. This, because I come from DC, is a map of the DC Metro. And as you can see, it really depends on where you are on the same metro line that determines your life expectancy. So living on the same red line, which is the one that I take, you could be, if you're living on the very end of it, you could have a 7-year greater life expectancy than if you live in downtown DC. To me, this is significant because the implications are on built environment design, right? So what is driving this gap in life expectancy is a question that comes up. Another example, because sometimes these impacts of the built environment design and policy are directly visible and may result from decisions made in our lifetimes, but other times it's only by layering sort of various pieces of evidence and specifically historic policies and practices rooted in systems of discrimination that we uncover inequities, right? So this is a redlining map of Baltimore. For anyone that doesn't know what redlining is, you probably heard it yesterday, but I'll just repeat that it is a discriminatory practice started in the 1930s or so, where geographic areas were effectively demarcated as off limits for issuing loans, which means it segregates housing, right? Now, if we layer that with current map of, current map of poverty rates, relatively current, and layer that further with life expectancy, do you see a pattern emerging? You see where I'm going with this? It's the same pattern that has existed in from redlining to poverty to life expectancy, direct health outcomes. So that brings me to why a focus on equity is critical to design. Equity is distinct from equality, and I want to make this point very succinctly. Equality provides each person or community with the same amount and types of resources, but equity really recognizes that each person or community starts at a different place, right? So they may need different types and amounts of resources to achieve similar outcomes. So equity requires that all people and communities have the conditions that they need to achieve their full potential. It is both a process and an outcome. And so how we design the built environment, how we design the process of the design of the built environment play a big role in achieving equity. While equity is the immediate goal, the ultimate goal is justice. And justice is about dismantling the structures and systems that keep access to resources unequal. So you see that last box there on the bottom right, which is justice, essentially bending the tree to become straight. So really breaking the systems that keep us perpetuating the same built environment policies that are rooted in systemic discrimination, like redlining, for example, and deconstructing design of our environments in ways that stop us from replicating the past mistakes. Okay, so this is central to our work at the Health Impact Project. Here's a quick acknowledgement to our current team. And as I said, we're funded by Robert Wood Johnson Foundation and Pew, and we're located in Pew offices in Washington, DC, where Pew's goal is to improve public policy, inform the public, and invigorate civic life. We were launched in 2009, so it's been a almost 12-year journey, with the goal of really encouraging state, local, and national level organizations to include health considerations in policy decisions across many sectors. So housing, transportation, education, criminal justice, because all of those things impact our health. Now, we do this primarily through grants and technical assistance, trainings, convenings, but really encouraging organizations and policymakers particularly to identify health promoting policies, practices, and research, evidence informed, to integrate into their work. Our work generally falls in 4 main categories that you see there: place-based grant making, strategic partnerships. And when we say strategic partnerships, I mean bringing unusual partners to the table across multiple sectors to really have those conversations about health. Research and evaluation, because we continually want to improve what we do and how we do it, and knowledge building and sharing as a practice. So in our work, the relationship between built environment and health has been predominant because, of course, health and well-being happens in place, right? It's a place, we're all existing in space and creating place. The physical environment directly contributes, therefore, to our health in many ways that we as environmental design researchers and practitioners can influence. So housing, we know that availability, affordability, location, community, quality of housing affects our health. The range of transportation options that we have, the mode, the affordability, the infrastructure of that, how close it is to where we are, impacts our health. Certain types of land uses like brownfields and freeways expose us to more pollutants and effects and has direct health effects. Our access to green space and our access to green space and how we the features therein are going to affect how we how it affects our health and well-being. Access to goods and services and employment and education opportunities. And even the land use and planning decisions and built environment decisions we make that help address and prepare us for disasters or emergencies is going to impact our health. A really key piece of this, the one on the bottom there, is about social cohesion and safety. Again, design informs social cohesion and what social capital we have, which then impacts our health. So, and all of this, and the context of all of this infrastructure, as well as the social networks that we create, can help us be more resilient as communities, whether it is climate resilience or other types of resilience, and really help improve our well-being. So what I want to do now is, while we understand the relationship, right, between these built environment factors and health, how do we center health equity in both design and policy strategies related to these factors? So the good news is there are a lot of evidence-informed strategies to do that, and I'm going to show you a couple of examples that are emerging examples of sort of those promising practices and policies. So the first one is a land use and zoning policy called Complete Streets, and Complete Streets principles really seek to ensure safe and comfortable streets as a policy objective in design practice. These elements vary based on community need, but typically include things like safe sidewalks, bicycle lanes, special bus lanes, accessible public transportation stops, frequent and safe crossing opportunities, etc. And putting these practices in place can really benefit community health. Jurisdictions see fewer injuries, they see lower rates of asthma and respiratory disease because there's obviously less cars and less crashes, less vehicle emission, and of course it boosts physical activity because it increases the opportunity for walking and biking. Now, since health equity, as I said, is both a process and an outcome, it is really critical that when jurisdictions engage in a Complete Streets policy, for example, that they take into account resident input so that you can meet specific needs. Therein lies the equity outcome, right? Another broader and sort of longer term strategy to include health and equity is integrating it into comprehensive planning. So this is a planning related term, which essentially a comprehensive plan serves as a foundational policy document for planners that guide sort of long-term decisions about the built environment. And we're talking about spans of 20 to 30 years. But think about it, if we were to integrate health and equity into those decisions upstream, then the decisions that you see being made across those 20 to 30 years could result in improvements in health outcome and potentially equitable outcomes across communities. So through some of the work we've funded with the American Planning Association, they developed a toolkit that helps planners consider health equity as an integral component of comprehensive plans, both in process and in content. Another example, and this is an emerging promising strategy, is the concept of resilience hubs. So if you are from Baltimore, you will be familiar with these potentially. Resilience hubs are essentially a neighborhood center that is designed to coordinate culturally sensitive multilingual services to better meet the needs of diverse groups of community members. So in addition to sort of the day-to-day benefits, hubs also can provide a safe place for temporary shelter and relief during things like extreme heat days, which is more and more common now. And it can also operate independently. And when I say independently, energy independently, sorry, I'm going to go over a little, energy independently during times of disaster or floods. So year-round, they offer programming that supports community building efforts and then also increases resiliency during emergencies. We have funded some of these resilience hubs in Baltimore and Minneapolis, and other cities are following suit, as this is something that will be more and more common as we move towards climate change and its impacts. So if you're curious to learn more about the connections between these interventions and health equity, I have some QR codes here. I'm happy to share this also to read some short articles about this. I'm going to very quickly go through a couple more. Sorry, these are the QR codes. I'll get back to that in a second if you're interested. I just wanted to say that during the pandemic, we have seen the cracks in the system highlighted by COVID, right? You can see these headlines that illustrate sort of existing and persistent problems in communities that are directly connected to health, but also connected to the built environment. Now, these issues are not new, right? These communities have faced these challenges of access to housing, access to healthy foods, broadband, unbiased and quality healthcare for decades. But through our most recent initiative, it's called Breaking Barriers to Better Health for All, we've supported to both address and potentially redress some of these issues that the pandemic has highlighted. And these are pressing built environment issues. Our work is primarily focused on policy change in order to address this. But of course, environment behavior studies as a discipline has been the home of sort of the foundational research in which these promising practices and policies are rooted. So if you think about it, I'll share a couple quick examples, 4 examples, and I'll show you how it is rooted in that research. Sorry, those were the headlines. Okay, so the first one is vacant lot revitalization. COVID-19 really underscored the need to have access to outdoor spaces, right? And gathering spots outdoors for both exercise and socializing. In Philadelphia, the city has really struggled with 42,000 vacant lots in the city, really struggled to revitalize those lots and have access to those green spaces. And mostly low-income neighborhoods and communities of color are the ones that are most frequently excluded from access to those green spaces. So here we funded the city's an entity within the city's planning commission called the Citizens Planning Institute, along with the landscape architecture program in the Thomas Jefferson University. And the students and faculty at Thomas Jefferson came up with something called a park in a truck. It's basically a modular way of designing very fast and low cost solutions for schemas to redevelop these lots. And then through policy interventions, try to see how residents and citizens can have access to that land. And they were trained through the Citizens Planning Institute under the Planning Commission to have access to those resources and be able to develop it on their own. second example is based in the connections between basic infrastructure and health. Disadvantaged unincorporated communities, these are also called DUCs, DUCs, are neighborhoods where the government, because of government neglect and disinvestment, they face lots of issues such as lack of recognition and representation in local decision making. And so, of course, are left out of infrastructure decisions. And that drives health disparities and higher rates of pollution, heavy traffic, et cetera. So during our early days of COVID, for example, when people are asked to wash their hands, it's difficult to follow those recommendations, public health recommendations, when you don't have basic running water. And this is a place in California where it's Central Valley, California, where these ducts are located. But to address this, there are specific interventions, design interventions that are creative interventions that can be uniquely positioned by environmental design researchers, for example, to advocate for those infrastructure needs. I have 2 more slides, I promise. And this example is about food insecurity in indigenous communities. And this was really about decolonizing food and breaking what we call the green ceiling. This is a project we funded in New Mexico in the Zuni Pueblo, where food security was a challenge during COVID, but food security is not always resolved by just transporting food to places, especially in indigenous communities. So a local community-based organization promoted community gardening as a way to really support food sovereignty, which is the ways using cultural practices that are rooted in their traditions. And Zuni is a water scarce community. And so trying to implement these strategies when it is a water scarce communities means creative design solutions to get water, such as rainwater harvesting is one of the ways that they did that. But I think as environmental design researchers, again, we are uniquely positioned to examine creative and alternate solutions that support food sovereignty in water scarce communities. And the last one is a project related also to food insecurity, but this is in Louisiana, where food insecurity is extremely high, particularly among children. So 1 in 4 children in Louisiana are actually food insecure, which essentially means that they don't have access to nutritious food on a daily basis. They access food through schools. So what happens during COVID when schools close? There is no access to food. So how can we leverage built environment infrastructure and to get food to children? This was the project that really we were trying to leverage school-based infrastructure, but in Louisiana, because there was no policy by the Department of Education to say how to leverage that, schools just stopped feeding children. And so this policy was put into place. However, again, as environmental design researchers, there are many creative design solutions in the environment to get food to children. So I want to close just by saying that sitting at a national nonprofit, we see sort of these many built environment related challenges in communities that contribute to poor health outcomes. Because a significant part of our health is rooted in place and facilitated through behavior. So we as environmental design researchers have a pivotal and central role to play in promoting health in communities, specifically addressing health inequities. So my call to action for you today is to really bring this research we already have to, and have been deepening for decades, to policymakers and decision makers so that they can advance evidence-informed built environment policies and practices that improve health and well-being in all communities. Thank you so much.
Perfect. Good morning, everyone. Can you hear me okay with this mic? Okay, great. So first I want to thank Anjali and the organizing committee for inviting me to be here today. It's actually my first EDRA, and realize it's EDRA, and it's been a pleasure to be here. and to learn about all the wonderful work that your community is doing. So I just talk a little bit just about my background, since I'm new to this space. And so my work is at the intersection of systems engineering, but also cultural anthropology and public health. And so that's some of what I'm going to talk to you about today. And most of that work has been done in partnership with marginalized communities, kind of centering different aspects of identity and lived experience depending on the work I'm doing. And today I'm going to talk to you specifically in the context of centering the disability community. And I want to say upfront that I identify, I often say multiple times over, as disabled, which is why I'm sitting here in front of you today. I am a wheelchair user. And also, I can't look at screens for long periods of time, so I have everything printed out. So kind of my somewhat atypical way of presenting is based on my own experience as a disabled person. Next slide, please. So I thought I would begin, since often the disability community is not often recognized or conceptualized as a community that experiences disparity. So I wanted to talk about this in a historical context and also about present day in the context of the pandemic and just more broadly in terms of societal disparities that are faced. So I want to start with this idea, in terms of disability community and history of eugenics, institutionalization, segregation, and this idea that, as a community, we have been sterilized, warehoused, euthanized, imprisoned, because our voices, our brains, our ways of being in the world physically have not been considered acceptable, right, to kind of mainstream society. And this continues today, right? And so we've talked a lot about the pandemic here. The statistics related to the pandemic are shocking in relation to the disability community as well. And so I have one of those statistics there, right, in terms of the death rate experienced by the disability community in the context of this pandemic. Next slide, please. And then I wanted to highlight kind of these disparities across multiple other dimensions, all right, of our society. So one is related to healthcare. And one I think that's very specific related to attitudinal barriers, but also structural barriers and those related to the built environment. And that is that over 75% of individuals with disabilities report experiencing barriers that impede them from using health and wellness services. And I'll dig a little bit into that more deeply since a lot of my work is, of course, focused around healthcare. But I also want to point out this idea that people with disabilities experience disparity as related to employment and socioeconomic status. So the median income for someone who is disabled is around 20,000 versus someone who is non-disabled around 30,000. So again, a widespread disparity. And that about 2 in 5 individuals who are incarcerated are disabled. Next slide, please. So, who are we talking about? What's the prevalence of disability? So in the US, based on the American Community Survey, it's 1 in 4 Americans are disabled, which often surprises people in terms of the sheer prevalence of disability in our society. And then worldwide, it's about 1 in 7 individuals. Next slide, please. So I say this and it probably sounds obvious, right? The disability community is not a monolith, but I put on this picture of a wheelchair because I think when we think about international symbols of disability, it's often a wheelchair user. And I think that's a lot of times where people's brains go initially when we think about, who is someone, what does someone look like who is disabled? But of course, right, disability it takes on many forms. We think about physical disability, of course, we can also, let's include sensory disability, cognitive disability, people with mental health related experiences as well. And then I also like to point out, right, people with the same disability may have vastly different lived experiences. So this may be that you have the same diagnosis, but the symptoms you experience are different. But it's also a way your experience as a disabled person intersects with your other identities, right? So experiences in terms of race, ethnicity, socioeconomic status, right? The family in which you were raised, your experience in terms of identity, in terms of how you may be integrated or not integrated into a broader disability community. So we talk about disability sometimes as a marginalized community that you are born into, but not in terms of necessarily your family experiences, or that you acquire. So for me personally, right, I consider that I became disabled a little over a decade ago. So kind of an identity transformation there too. Next slide, please. And then this other point that, as we talk about disability, I often assert that this has to be integrally viewed as really very closely linked to discussions about other marginalized communities. So if we say 1 in 4 Americans are disabled, this rises to 30%. If we talk about veterans, it rises to 33%. If we talk about individuals living in rural communities, 40% if we talk about older adults, 65 and older. And then disability is also overrepresented in Black communities and Indigenous communities. And when you look at older adults who identify as Hispanic and those communities as well. So when we talk about disability, it's not separate from talking about other marginalized communities and talking about health equity, right? More broadly speaking. Next slide, please. Okay, so I'm going to talk about two different imperatives is sometimes how I frame this. And so there's, of course, a legal foundation for thinking about providing the same level of access, same quality of healthcare or any other types of service that we're providing, and certainly in terms of designing spaces. And so I'm going to talk about two pieces of legislation to begin with. So one is the Rehabilitation Act. This is from the 1970s. I have kind of two different parts of this. Section 504 and Section 508 are the two that are considered the most relevant often, or certainly the ones that are the most highlighted. So that persons with disabilities must have equal opportunity to receive program benefits and services, and that federal agencies must make their information and communication technology accessible to everyone. And I'm going to kind of get into the digital space a little bit later in the talk. Part of this related to digital accessibility is in the 2017 revision of the Rehabilitation Act. There are web content accessibility guidelines that are enumerated, and this is required for all federal contractors, federal agencies, but certainly is not widespread in terms of adoption beyond that space. And even in that space, right, there's still work to get up to speed. And then the other part, the other legislation that many people know about is American with Disabilities Act from 1990. And here we say persons with disabilities must have full and equal access to state and local governments, public places, and businesses. Again, this refers to the built environment predominantly speaking, even though ideally this would encompass attitudes and beliefs and everything else. There is a huge gap in enforcement, right? So enforcement of the ADA requires someone to file a lawsuit, right, for enforcement to happen. There is no other mechanism of enforcement of the ADA. And so there is a problem certainly related to enforcement. There is also a problem related just to awareness. If you look across multiple different spaces in our society, the awareness of what needs to happen under the ADA, whether you are a healthcare institution, whether you are a restaurant owner, whether you're a hotel owner, it doesn't matter. There's a lot of lack of awareness about what those requirements are under the ADA. And so part of my motivation for today's talk is to say that until there are other mechanisms of enforcement as designers, right, that burden of trying to meet the spirit of the law falls upon us, right? That there are no other mechanisms for that happening. Next slide, please. So in addition to this legal imperative is the design imperative. And of course, as designers, this is something that we all know about. And so this rationale for me emerges from principles just of good design, right? If we are creating robust technology, if we're creating robust physical spaces, and we believe in this idea of creating alignment between, right, the people for whom we're designing or with whom we're designing, and right, whatever it is that we are designing, that this should encompass all people, right? And so this is a design imperative. And certainly the concept of universal design, I'm sure is familiar to most, if not everyone in this room. And this emerges from the disability rights movement. And the idea that if we recognize and remove barriers that are faced by people who are disabled, we are also removing barriers for all individuals. So one example here is we talk about a push button or automatic door. So myself, I have limited strength in my arms, in my hands, and especially if I'm also using a wheelchair, for me to open many doors is really difficult. And so a push button is great, an automatic door is even better. But that can serve many people, right? That can serve somebody who is bringing in a bike, someone who is pushing a stroller, somebody who has their hand full because you're getting ready for a conference and you've all the supplies to bring in, right? Whatever that may be, that it benefits more than the disabled person who may have been the initial, right, rationale for creating that design change. And I also like to talk about this in the context of disability. Sometimes it can, I think there's some sense of being overwhelmed by designing for disability because, oh, there's so many different accommodations. But I also like to point out sometimes it's one accommodation like the automatic door. Sometimes I talk about adjustable exam tables in a healthcare setting, right? That can serve many people. It can serve somebody who needs to transfer from a wheelchair, someone who is feeling fatigued or dizzy that particular day, right? Someone who has a height that's on right one end or the other of a kind of a normal distribution, right? There's lots of reasons one specific change can serve many individuals. Next slide, please. So I think this is kind of right. That's systems are not designed right now to accommodate people with disabilities. This is certainly physical spaces in terms of systems. It's also digital spaces. And I'm going to get into digital space and give one example related to telehealth, because sometimes telehealth is seen as a way to kind of get around, right, physical inaccessibility. And I'm going to talk about kind of problematize that. But first, I want to talk a little bit about how to partner with the disability community in doing design work. And I'm going to draw on a lot of the research I've done, again, with the disability community, and a lot of advocacy, since a lot of my time is spent doing advocacy work as well. Next slide, please. So the first, they put it into like 5 categories. So the first is this idea of understanding the broader disability context. And I think this is not specific to disability community, although also really important here, is that when working with any marginalized community, how essential it is to understand the broader context and history of that lived experience, and to draw on that, right? And to come into those interactions, having spent time learning about that history. And the disability community, like many other marginalized community, has a history of distrust related to extractive research, extractive partnerships. And so again, acknowledging that and coming in knowing that history is essential. I also talk a lot about becoming familiar with contemporary debate. So one debate is related to language use. So you'll see I kind of go back and forth between saying people with disabilities, which is considered person first language. And the idea there is the importance of recognizing one's humanity before saying disability. And then saying disabled people, which is considered identity first language. So someone like myself, I identify very strongly as disabled. There's, concepts related to disability pride. And so often, in giving a talk like this, I'll go back and forth between language, because sometimes one language resonates with some and not with others. But this is just an example, right, of kind of a contemporary debate within this space. And then understanding what we call the relative appropriateness of a medical versus social model. So a medical model says that disability stems from an abnormality in the person. It's inherent to the individual, versus that it stems from the social space, right? So that disability is caused by the interaction between a person and their environment, right? And so I am disabled if there is not a ramp, I can't get up here, right? It's not my body, it's the physical environment that disables me. Next slide, please. So the second thing is this idea of partnering with the disability community. So a motto, or kind of a phrase that is very dear to the disability community, is nothing about us without us, which I'm sure many of you have heard. So this idea of building these strong relationships, I know we're gonna get into this a little bit in our discussion, so I'm not gonna spend too much time here. But this idea of building long-standing, trusting partnerships. And again, this kind of goes across all work in this space. And I also talk about when you can't do this, right? There's other ways to bring in that that essence, right? Or that philosophy in terms of having a community advisory board, about doing what I would call maximum variance sampling. So bringing people with different lived experiences, and not just about disability types, but how disability intersects with the other identities, to bring in that experience. Next slide, please. This gets to this idea of intentionally engaging a diverse sample. And so again, across disability has a lot of different definitions, sometimes by diagnosis, sometimes by functional ability and disability, sometimes by whether you have an identity as a disabled individual. So thinking about all these different ways of conceptualizing disability when you're thinking about who you're going to bring to the table. I think I bring up intersectionality over and over again, but I really believe that, again, your experience as a disabled person is shaped by all of these other identities and experiences that you hold. And this idea of basically creating a lot of different ways of engagement. So thinking about written forms of engagement, pictorial forms of engagement, verbal forms of engagement, again, to create as much access as you can. Next slide, please. I'm gonna run out of time, I think, just like you did. The fourth one is this creating responsive and accommodating design activities. And I could spend a lot of time talking about this, so I probably we'll try to go a little bit quickly here. But the biggest thing I would say is asking early and often about accommodation needs, right? Engaging anyone here, engaging in your design process in this conversation early on, creating an open space for that dialogue to happen. So if you're thinking about things like consent, thinking about, again, creating multiple different ways of doing that, verbal, making sure it's in plain language, because it's gonna be a really challenge, right, working with an IRB, but if anybody wants to have that conversation, I'm happy to have it, right, how you have those discussions with your IRB to do that. Thinking about coming prepared with alternate approaches. So everything from if we use tech-based ways of like a tablet for collecting data or having somebody interact with what a design looks like, thinking about styluses, thinking about multiple other forms of material that you may use that are tactile. So somebody who doesn't want to engage with technology for any reason because, right, that's not the best way for access, but also becoming really familiar with all the accessibility features on a tablet, right? So that you can help someone learn how to navigate, right, a technology that you may be wanting them to engage with. And then thinking about the physical spaces in which you're doing any of these design activities. I like to do a lot of work in people's homes because often people's homes and community spaces are designed in ways that are accessible for them. And when that's not possible, thinking about spaces and asking again about accommodation needs. So does somebody need that push button to get in? Does someone need an adult changing table, right, in the space that you're in? So again, just being really thoughtful about the range of types of accommodations that somebody may need. Next slide, please. And then the last bucket here is this idea of building foundations for future work. So one is this consistently recognizing the disability community as a population that should be engaged in all of our efforts. We're not just designing for disabled persons, but like disabilities all around us. And so thinking about that as just a key component of any design process, not something special or an add-on at the end. And that all of us as designers have the ability to, again, to advocate for clear and more comprehensive standards related to accessibility, and that has to come right from larger and larger communities of designers, because that isn't happening, and that is a role that we can play in terms of not just in our own solitary design processes, but thinking about policy and how we advocate for these changes on a larger scale. And then this idea of, which I don't have up here, but that recruiting people who are disabled to be a part of your design team, right? So this idea of meaningful representation in the design process. Next slide, please. So one example I like to bring up, which is not a research-based example, but an example, just again, a pandemic-based example, is having vaccination clinics that were focused on our disability community. So I have longstanding partnerships with several community organizations. I'm in Charlottesville, so related. One is called Bridgeline, which serves people with traumatic brain injury. Another is the Virginia Institute of Autism. Another Civic Access, which serves our deaf and hard of hearing community, and our local Center for Independent Living, which is a federally funded center that is run by disabled people for other disabled people. And during the pandemic, again, realizing all these disparities that were being faced, and realizing that getting to a vaccination clinic was really difficult for many people. There's not ASL interpretation, for example. You are in a crowded space with incredible sensory stimuli, with just the number of people, with fluorescent lights, in a stressful environment, not having, if you're trying to cram in as many people as you can, not having enough space for a wheelchair to maneuver. So this was a lot of work with our communities, one, to create clinics that were specific times where we carved out and rearranged spaces that were specific to needs that people requested ahead of time. But then also working with our academic medical center, but also our public health department, so that our large scale clinics were redesigned for accessibility. So everything about creating spaces off the side that had low levels of stimulation, sensory stimuli, to making sure that there was always an ASL interpreter available, just thinking about the range of ways to create access, and then doing in-car vaccinations, for example, before that was considered standard of practice. I think I should stop there. I have a thing about telehealth, but Angela, I'll kind of look to you if you want to keep going. Okay, next slide, please. So I thought I would talk to you a little bit about telehealth as an example, because sometimes, at least in the context of healthcare, the idea that, when you're back to the statistic that 75% of people with disabilities talk about the barriers they face to telehealth access, to physical access of healthcare spaces, that telehealth has sometimes been seen as a way around this for the disability community. If you can get care from home, then you don't have to deal with inaccessible spaces. And the point I wanted to highlight here is there are some potential benefits, absolutely, of telehealth for the disability community. And this is some of what the discussion is happening, but there are lots of challenges with telehealth too. And so not for it to be seen as a panacea, in terms of access for healthcare. So in terms of a potential benefit, one is what I often refer to as reduced patient work. So the work of being a patient. So for myself, I have not driven in over a decade. So for me to get to any healthcare appointment, I rely on paratransit, I rely on friends and family, I relied on a dear friend to get to this conference. And so not having to negotiate that transportation has been huge in terms of telehealth. Of course, I get to avoid inaccessible spaces. My home is designed in a way that's accessible for me. Healthcare spaces are often not. And then this idea of improved healthcare access and quality. So as there was more flexibilities under kind of telehealth waivers, you can seek care across state lines. It reduced wait times for people who are disabled. It increased access to specialists. There was a lot of benefits that came out of telehealth. Next slide, please. So, next slide, please. So that said, right, back to this point, this at the same time, right, use of telehealth can also be a way to further exacerbate inequities faced by people with disabilities. So why might this happen? Next slide, please. So one is related to design of telehealth systems. So I talked about the Web Content Accessibility Guidelines is coming out of the Rehabilitation Act, the revision in 2017. That said, there is very little compliance with the standards that exist. And there is very little engagement in any user-centered design process. We talked about all these ways of engaging with the disability community. That does not happen. I wouldn't say not just on a regular basis, it pretty much just doesn't happen. And so there is, like, accessibility is just not part of the process of telehealth systems. And certainly in the kind of the speed at which they were developed and implemented in practice because of the pandemic, that was even less so the case. There's also not a responsiveness to individual needs. So we can think about kind of usability of systems that exist, but we can also need to think about usefulness. So often telehealth is conceptualized as an interaction between one patient and one clinician. That is not always how someone who is disabled needs to interact with the healthcare system. So you might need to have someone like an ASL interpreter. You may need to have a speech-to-speech translator. You may need to have a qualified reader. You may need to have a care partner, right? Somebody who's a family or friend there. And so you may have 4 people in 4 different locations, right? Particularly in a pandemic setting. A telehealth system is not designed to support that type of interaction. And then lastly, the idea of compatibility with existing technology. So both in terms of external assistive technologies that someone who is disabled may use, that compatibility was often not designed into telehealth systems. And then accessibility in terms of implementing the accessibility features that are already present in operating systems, right, in terms of the design. Next slide, please. So we can imagine a world in which we've designed this perfect telehealth accessible technology, but then we have implementation problems. So broadband access, which, you know, of course, you know, everyone is aware of, is a huge problem. People who are disabled also have disproportionately less access to broadband, disproportionately less access to the hardware that's required for accessing telehealth services, which leads to, of course, everything from canceled appointments to misinterpretation, right, of clinical advice, and certainly overall to lower quality of care. There are some clinics now who started providing access to technology so that you would ship somebody a tablet with accessibility features implemented, right? There's ways to think about how you may be able to design that interaction. There's some who have done training, so the test run. So there's some work in the disability community related to transportation and aviation. There's a program called Wings for Autism, where you can have somebody go through who on an autism spectrum disorder can go through the TSA system at an airport before a flight, so you're aware of it. So at the moment where you actually have to go through it, you've had the practice of going through it. So modeling that type of training for patients right before they go to it through a telehealth encounter, and certainly for clinicians too, who may not have any sense of how to use the accessibility features, right, that are built in. Next slide, please. And then finally, thinking about policy considerations. Right, this back to this idea that we need to create, just like we talked about creating better regulations and standards related to how we design the built environment. That is also true for technology-based spaces. There's not a lot of specificity in what this should look like. The idea of monitoring, everything from health to patient-centered outcomes. There is a fear among people who are disabled that, what I was circling back to, or talking about at the beginning, that if we think about telehealth as a way to for cost containment, right, to reduce costs, but also as a way to basically say we don't need to think about accessible physical spaces, that more and more people who are disabled will be intentionally or unintentionally encouraged to have digital interactions, right, with a healthcare provider. But that reduces quality of care. We know that people who are disabled can have challenges from everything from like positioning a camera appropriately to just not having, right, the in-person encounter that's necessary for appropriate diagnosis and appropriate treatment. And then this whole thing about, of course, like cybersecurity and HIPAA flexibilities that we can talk about later. Next slide, please. So my last slide is just basically saying that addressing, right, disparities, whether we're talking about healthcare, which of course is the focus today, but in all of these other spaces from education to employment, really requires this multidisciplinary effort in terms of academic disciplines, but also partnerships with the disability community to think about both how we're designing physical spaces, how we're thinking about hybrid spaces in relation to technology, and then thinking about what those unintended consequences could look like and designing for those ahead of time. Thank you.
Good morning, and thanks for all of you guys hanging in there and coming this morning. And I want to thank the organizers for organizing this, and Mimi very thoughtfully thanked the land permission. But I'm also like to ask the ancestors and elders of a place for permission to speak in their place at this time. I was asked to talk about disparity in healthcare for U.S. indigenous communities. And I'm sure this maybe seems silly, but I need to point out that we're not talking about a single community here either. There are somewhere between 800 and 4,000 different Native communities in just the U.S. You can sort of see here a bunch of them sort of at the moment of colonization, but you know, some of these communities are recognized by state and federal governmental groups, and some not at all. And that's a kind of important sort of quality. Let's see, it doesn't change quite as fast as you think. You know, we also know that as part of the colonization of this country, we moved people into less and less lands, and eventually we moved a lot of people into places that they weren't familiar with. The map on your guys' right shows all the communities that were moved to Oklahoma and where they came from, so you get a little bit of sense of that, just one small thing. And so folks, indigenous folks, were subjected to a whole lot of European germs that they weren't really familiar with or didn't have ways of dealing with. But they've also had to learn to live in a place that was very different than perhaps where they traditionally made place. And you can sort of see the whole sort of reservation or reserve kind of issue, how it changed in Ricardo Cate's little sort of commentary about gated communities and reservations. But we're also talking about urban groups. Also, many of the US Superfund environmental sites are on tribal land. And this is an important thing about the quality of healthcare. We impacted the food sources, both the way food could be gathered or harvested, and the natural environmental kinds of food that were available. You know, killing off the buffalo in the plains is a good example. It's not the only one, but it's maybe the one we're most familiar with. And, you know, so when we put people on reserves and we took away the habitat for traditional people and so on, that was, and I'm using people there for four-legged and winged people too. We also took Native people and put them in boarding schools. And as a part of that, that created some things that were really problematic. They took students very far away from their home. They weren't allowed to continue cultural practices or language. They were the subject. I'm not saying that all of the boarding school experience was terrible, but there was a great deal of abuse, both mental and physical and sexual. And the students learned a lot about living in an institutional system, but many of them never got to live in a family situation again, or learn how to have other kinds of normal social relationships. And that historical grief has contributed to even now long-term health disparity issues in terms of alcoholism, drug addiction, low self-esteem, and that's led to suicide and other things. And this is this identity and the limited vision and hope has had a big impact on our young people. And one of the things that many Native communities are working on is programs for young people that build cultural and self-esteem awareness and try to build back a more positive sense of the future and one's own sort of control over it. But the numbers of people are still really problematic. Also, perhaps many of you know that in the 40s, there was a big push to get folks to move off the reserves out of local communities and into urban areas. And you see some of the highest urban areas here. The government was sort of hoping that if they would do that, then they wouldn't have to meet their treaty obligations. Not, of course, that they ever did, but there was this sort of concept about that. One of the sort of, biggest primary provider of healthcare in Indigenous populations is the Indian Health Service, which is a government group run out of the BIA or the Bureau of Indian Affairs. And you can see here where some of those locations are. So one of the things that you can notice is that those are not very accessible places for a lot of folks. And of course, there are a huge number of jokes in Indian country about the care at Indian Health Service organizations. I won't tell any of them here for timing, as well as properly dealing with the sort of thoughtfulness of a community here. But, the care is problematic and access to it is really difficult. And this is also true for veterans and Veteran Affairs Hospital. And you should know that the Native populations in the US serve in the armed forces at a higher rate than any other group in the US. And there's a huge number of Native veterans, and a very, very small number of them can access veterans care. So that's kind of important. I mean, veterans care is bad overall, but it's really bad for the Native community. So this is an issue about access and so on. Also, we want to sort of think about the quality of that care, not just in terms of what we might sort of think of as mainstream medicine, but also in terms of how it relates to traditional ideas of sort of healthcare and healing and what's appropriate. There's been some movement to address that. One of the things is to increase the pipeline of Native people in healthcare. That's been, positively impacted by so I'm a little behind here. There's all the veterans. You see the code talker there. Sorry, it's not going as fast as I think it should. Hello. One of the things is to get that pipeline going. I'm going to use as an example my good friend Brett Bentley Thompson, who started out as a tribal policeman. You think, oh my God, really? And said, this is not really me. And as a 40-year-old, he went back to medical school And he's now a family practitioner and a palliative care doctor. And he also takes it on as a serious mission to provide mentoring to a whole lot of Native students who want to go into any sort of level of medicine, which is supported a lot by the American Indian Science and Engineering Society. And Brett is now one of the elders. But this kind of stuff, like a real person that people can talk to, is really important. One of the things that we want to sort of talk about is as well, might be sort of the whole sort of issue about germ warfare. The title of my talk was perhaps a little bit provocative, but many of you are probably familiar with while there's a lot of distrust of the US government, not only for the similar kinds of reasons that were mentioned before for other marginal communities, but during the Plains Wars, one of the things that happened was that the guys who were in the forts, and they knew better, they would never have kept smallpox blankets or clothing worn by soldiers who got smallpox and died. But somebody had this bright idea, because around many of the forts were a lot of Native people who were in pretty serious distress. So they knew that they would, if they put anything outside of the fort, it'd get picked up and used. And so they put all the blankets and clothing outside of the forts, and folks came and got it. And of course, then spread smallpox through the through the community. And that's maybe one long-term example of why that's true. But we also know that there was a lot of times when Indigenous women would come into clinics or healthcare and give birth to kids, and they were told that the babies were stillborn or died after minutes, and they were really being, especially if they were fair, were being adopted out to white families. And, those folks are often still searching for getting back to family because it causes a whole nother set of issues. And there was a lot of forced sterilization and some experimentation on Native folks, maybe not as blatant as the Tuskegee Airmen, but in the same sort of general sense. So people are really touchy about these kinds of things and not so anxious then to trust things like getting COVID vaccinations and so on like that. But a lot of us were really impressed because many of the Native communities, both rural and urban, got themselves organized and took control and got vaccines in their communities and in the arms of Native people in a pretty fast way. I mean, I lived in Iowa where it was like really hard to get the first shot. And I had friends all over Indian country who were saying, what, you haven't gotten your first shot yet? You got to come out here, we'll give it to you. So it's, it's sort of an interesting kind of fact. And one of the things that that happened, the Coeur d'Alene are a good example of that. This unit are in Idaho. And one of the things that they did is they consider themselves to be hospitable. That's the definition of who they are. And so they opened their clinic to anybody in the community. They live on a checkerboard reservation. Didn't matter if you were a tribal member, not a tribal member, indigenous, not indigenous. And they were like getting people in and moving them through. And they also, for a lot of the people who are a little reticent to see the fact that like mainstream folks were getting vaccinated too, made a big impact on their willingness to get vaccinated. They were also really great about getting out to elders and others who are not able to get into clinics and get them vaccinated as well, which is, pretty amazing. Also the Coeur d'Alene were really good. Indians love swag. We're into that. So one of the things, for example, that they did was you got your shot and you got a little swag at the end. So you got a little bag and it had a mask and hand sanitizer and cookies and juice and like a couple of other little prizes in the bag, because people have to kind of wait a few minutes after they get their shot, so everybody can sort of dig through their bag and see what they got. So that was another big plus for getting people in. But besides being on top of vaccination, one of the things that was happening was that many Indigenous people were really taking control of in their local areas, what kinds of, masking rules and so on like that, but also what kind of, ongoing checking and, so on was happening. And then the Pueblos in New Mexico, who are in sort of more contained areas, one of the things that they did right away was they literally closed the Pueblos, posted armed guards at the entrances. And you could only get in if you were a resident, I try to remember, and anybody who is going out to work, because, for a while, people were still going, had to be checked before they came back into the Pueblo. So that was like a big deal. And they put in place some other kinds of things that the Dene or Navajo, who are also there, had a little more trouble with that because they're really scattered out. They also had trouble getting access to clean water because water delivery in Dinata was really a problem. And so they had a lot more trouble. One of the problems, the Pueblos, they were losing elders like crazy. And the Pueblos were really thinking, what is going on here? We have this closed, we're really like, hello, where is this happening? Well, diabetes is a huge problem in Native communities. And so we have lots of people getting dialysis. And folks have to go someplace else to a clinic for dialysis. And it took a while, but they discovered that they were going out to get dialysis, and the dialysis clinics were not cleaning properly. They were not properly monitoring their workers. So guys, it was like, you have to have dialysis to live, but you're putting yourself in the COVID chain by going to get dialysis. And they tried to get a mobile truck. And as it turns out, they also have home dialysis units that they could have been able to provide to Native communities, and nobody would. So that's kind of an issue. And it got so bad at sort of one point that several of the governors and caciques, burial traditions are a really big deal in Native communities. And a couple of actually most of the Pueblos, their governors decided things like there are going to be no families at the funerals, and they're going to dig the graves with a backhoe, which is like, it's really hard for me to explain what a big deal that is, but it's a huge deal. And now they're trying to figure out how they're going to deal with the resultant sort of grief issues that haven't been dealt with because they weren't able to do the cultural practices. So it's like we have to kind of rethink what our kind of post-COVID grief issues and grief dealing that we need to do. So this is a big deal, but it's not that people aren't aware of it. They're really working on that in ways that not everybody might be thinking about. Another sort of issue besides COVID issues, and we talked about this a little bit too, are food deserts. And, most both urban and rural communities find themselves in food deserts. And, this favorite story of mine, the guys in the Lakota guys in South Dakota were really excited when they got a Subway store. Okay. Why were they excited to go to Subway store? Oh, they're green vegetables. We haven't seen any green vegetables being brought into the community for years. You're like, really? Oh my God. That's getting excited by like a few pieces of lettuce and tomato. We're like, oh my God. So this is an issue, and that's being worked on in a lot of different ways in a lot of different communities, but it has also to do with food sovereignty. And it's not just, sovereignty of traditions and getting foods, but food in the Native communities is seen as a kind of medicine. And proper eating is more difficult in certain kinds of situations now. I mean, so controlling certain kinds of food, particularly in our agricultural environment, are really hard. It's really hard. Many of you may know that Winona LeDuc, who's an Anishinaabe, and Honor the Earth have worked hard on management or wild rice and protecting the traditional wild rice beds from commercial wild rice. Any of you guys who buy wild rice at the store, it's not wild rice. It's like a whole different thing. Traditional wild rice or manamon has a high rate of protein. Manufactured wild rice is just starch. And you can harvest it mechanically and all that, but just not the same thing. And it's been a big push, and it's been really difficult to try to keep the wild rice fields from being anywhere where manufactured wild rice stuff can blow onto the field. So that's a big deal. But another example might be the Coeur d'Alene. And one of the things that they have really fought with the University of Idaho, particularly Boise, about is not letting them commercialize huckleberries. If you fly through the Northwest coast, you'll be in an airport and see like huckleberries in chocolate and huckleberry this and huckleberry that. So it's a kind of a commercial thing, but in the community, it's really important, and it's really not so easy to harvest. So it's a subsistence thing that a lot of people use to support themselves, is to harvest huckleberries and sell them, and also they just don't want them to sort of go outside and be changed by others. A huge amount, probably about 90% of the food that we think of in the world came from the New World, and has been greatly modified. The other thing that some of the tribes are doing, Coeur d'Alene are like that too. The water potatoes and the camas, they've been really protecting their fields. Fortunately, nobody else wants to eat camas or water potatoes, so they've been sort of okay on that front. Huckleberries are different, but water potatoes and so on are maybe not so exciting to people. So that's been pretty good, and they've been able to protect that in a certain kind of way. But they're also sort of working on that. The other thing that's happening with like community gardens and so on, Roxanne Swensel, who you might know as a famous potter from Santa Clara, she had really bad health things, including high cholesterol that no mainstream medicine was having any impact on. And she was really into permaculture, and she did some reading, and she, they were talking about how long it takes for a plant to adapt to its environment, which, they often say is like 20 generations. And one of the things that she got to thinking about is that they were really lucky because they've been small size, but they're still basically in their same environment. And so she wanted to see if they went back to traditional foods, if they could improve health. And so they had this little small experiment called the Pueblo Food Experience. And they had several volunteers who range from 6 to 64, and they did all these kinds of things. And then they ate traditional food for like 3 months of trial. And then everybody was tested again. Her cholesterol dropped to nothing. And her son, who teaches at AICAE, dropped about 50 to 60 pounds in that time, and totally dealt with his diabetes in a whole bunch of different kinds of ways. So it proved sort of beyond a doubt at some level that going back to traditional foods was a really good way to deal with things. The other thing that that Roxanne sort of pushed with women is to create the Bua Kiwa Tiwa, or the women's bread house or women's kitchen. And they partnered with the Hopi Pueblos in Arizona to rebuild their ability to make what the Hopi call piki, but which the Santa Clarans call bua. And it's like blue corn parchment or phyllo dough, and you use specially ground blue corn, and you have to have asbestos hands to do this because they wipe it on a really hot rock with their hand, and then they roll it up. And it used to be used for traveling food with pemmican, and so they're working on some of that, and also about how to cook for other people. The other thing is a kind of push to do, oh, sorry, that's the women's kitchen. The other thing is Three Sister gardening is being sort of pushed, and the Three Sisters are corn, beans, and squash, and they're planted in mounds. And the thing about them is that the corn is in the middle, the beans, and then the squash, and the squash protect, because they have big leaves, protects the evaporation of water, but also those sticky leaves of squash like get a lot of bugs that don't want to come into the plants because they don't like those leaves. And the poles grow up and use the corn stalks as a pole, and they put nitrate back into the ground, which, not using fertilizer, keeps water table better and kind of regenerates the soil. And then they don't plow under, they just sort of let the corn stalks and everything kind of compost in the ground, so they can always keep working in the same group. And Jane Mount Pleasant, who is Iroquois or Tuscarora and at Cornell, has been really pushing this. You might be familiar with it because they have a Three Sisters garden at the Smithsonian. How close am I on time? She hasn't shown me a number.
Oh, she has a couple
Oh,
times,
sorry.
actually. It's
Oh,
all right.
sorry.
If you're coming, we are amazed by the three of you.
Okay.
We want to make sure we can have a conversation.
Okay, so really quickly, the groups have taken control by doing some commercial things like making buffalo snack bars, the Tonka in the Southwest, and the Quest, which is in the Northwest Coast, a healthy food, that they're now doing this. And if you think this is only elders and middle-aged people who are doing this, let me tell you, it's not. I had my Iowa State students at ECMO. We met with a bunch of students and we were talking to them about what was needed. We're talking about an intergenerational learning environment, and kids like shot their hands up. One of them shot their hands up and I said, what do we need? He goes, we need a Mac Pueblo. And we said, what? And he said, like McDonald's, but Pueblo food, where they'll cook, and your mom, even if she has to work in town, she can come by and buy good food to have for dinner. So, for young people to be thinking about that, that's really important. And I think these examples show Gadaji, which is the Cherokee word for a spirit of duty or selfless service, working together for a common goal. And I think the really important thing is that Native communities are taking more control rather than letting other people try to control them. So with that, I'll just say wado, or thank you. And
I hope all of you are as impressed with, the ideas that we just heard about. We want to get into questions from the audience as quickly as possible. Sarah has the microphone. I would ask if you're on this side of the room and want to ask a question, we would love for you to migrate this way so that our speakers would be able to see you as you ask. Do we have any questions or comments? No, she's.
Hey there. This question is for Mimi. Thank you, everybody, for presenting. So quickly, I have a question about how this funding happens, right? So if these places where we want to make the streets better or bring in better schools and community centers and these kind of things, that's often done off of levies and bonds on the people who live right in those neighborhoods. And then their taxes go up, their rents go up, their mortgages go up because the rent that money is going there, right? So, and then they have to move out. So this is a whole big cycle, and I'm in schools and community centers, and I see that happen all the time. And I'm just wondering how to do that better.
Make sure that's on. Okay. Thank you so much for that question. So I think one of the things that we, at least in the Health Impact Project, have been doing is, first of all, the funding that I'm talking about is funding that comes from Robert Wood Johnson Foundation to really start to think about policy level, systemic level changes that can that can really inform those decisions of where to locate the schools and community centers and so on. When we do that, we know we have unintended consequences like gentrification and like people being displaced. And so one of the tools that we've been using at the Health Impact Project is called the Health Impact Assessment. And what that is essentially a research methodology. It's a way to assess what is going to be the impact of community health if a project moves forward or if there's a plan or a policy that's being implemented. And so through the Health Impact Assessment, where we go through a 7-step process of sort of assessing the baseline conditions of the community, then going into sort of what is the impact and what is going to be potentially the impact based on the implementation of that project. We make recommendations to developers or others, that policy makers, to mitigate negative impacts and to sort of promote positive health impacts. And then those recommendations taken up could potentially mitigate some of the things that you're talking about, those unintended consequences. And in the United States, we have been the organization that has pretty much spread that across the United States. We've funded over 200 of health impact assessments across the country, and have a resource on our website that now has a collection of over 450 health impact assessments that have been done. It is a tool that is regularly used in decision-making and policymaking in places like Europe, New Zealand, Australia, but the United States was a little bit behind on that. So it's what we hope that will be integrated into these decision-making processes in the future. I hope that answers your question.
Any other questions? There we go. Yes, ma'am, if you don't mind, maybe just migrating over here. That way our panelists can see you. That would be great. Thank you.
Thank you. Can you hear me? Okay. Really nice, terrific representation of perspectives. Really appreciate that. This question is for Dr. Paxson about sweat lodges. Has that been continued in a lot of the communities? Has it been incorporated more mainstream for people, especially around COVID? Can you talk about the status of sweat lodges? Thank you.
For the groups for which sweat lodges are, a practice, yes. In fact, there are a few native hospitals in different places which have created a place where those. Also, I might add, some prisons have provided those, but it depends. During COVID, it wasn't that the practice wasn't continuing, but it was modified in a certain kind of way so that it was, groups of people who were already, I'll say, living together or interacting together. So you weren't interacting in the sweat with a broader part of your community. But yeah, I mean, many traditional practices have managed to kind of maintain, not the urban areas, it was harder.
Anybody else? Other questions? Sarah's really good at getting the microphone to you quickly. Oh, right in the back, And yeah, if you head this way, that would be great. That way they can see you when you ask the question. Yeah, towards the back.
Thank you so much. Can you hear me okay? Or yeah, thank you so much for awesome sharing of ideas and stories, and it's really incredible. So I have a comment for Lynn. One of the most impressive things that happened in Indian country in Idaho is that the message about protect our elders, and protect our elders became really a main driver. I can't see now from this main driver of the masking and then the vaccination update. And so I wish that the rest of the world actually will learn from that, because it's not just an individual responsibility, it's a responsibility to one another. And I thought that was one of the most impressive things. So thank you about sharing all of these other stories. And for Dr. Rupa, I have a question. I do teach universal design, and we encounter or we have self-advocates who come and talk to the students. And of course, many of our students want a one solution fits all. And sometimes in that experience, at the end, because they hear from a person from the deaf deaf community, and then they hear from people who are blind and or have visual impairment, or people who might be physically disabled. And at the end, they come and say, well, everybody needs something different. And sometimes they contradict. And so maybe we just like, they feel at like they are not challenged to do one thing. And so of course, one solution doesn't fit all, but if there are any suggestions to help move that needle in their thinking, would really appreciate it. Thanks.
It's working. Okay. Thank you for that question. I mean, I absolutely recognize that. I mean, one example I can give for those who, just as a concrete example, is if you think about curb cuts, a good example. So if you're somebody who's using some type of mobility aid, a curb cut is really important. But there's also, for someone who is blind or low vision, you might have texturized, right, the curb cut, so that someone who's using right, a different type of aid, right, can have the feedback, right, in terms of the tactile feedback. And so, and that can kind of be at odds, right, in terms of making things accessible more for one than for another. So, I mean, there's lots of examples like that. And so, which makes universal design as a concept, kind of theoretically as a concept, really lovely, and in practice, challenging to implement. I do think, right, there's kind of some different ways of thinking about that. I think for the students, the thing I tell my students is this is where we get to be creative as designers, that we don't have great solutions for some of these things, and where bringing together people who have different experiences of disability is so important as part of that collaborative design process, that just us as designers may not be able to ideate about what would work or what, right, kind of innovative solutions we can come up with together. And then I do think over time, right, as we're able to generate those solutions, it's about codifying them and, right, and creating those into standards. But I think we have a lot of work to do as a design community in partnership with the disability community to think about what those solutions look like. And so maybe framing, I try to frame as my students as a space for, right, to exercise their ability to do community engagement, to do co-design work, and right, that there is a lot of innovation that still needs to happen in that space.
Thank you. I think we have a question over here.
Thank you all for your presentations. That they were all great. And so, can you not hear me? Okay, okay. Thank you for your presentations. I just had one question, and to know if you all had suggestions of the best way to come in and partner with communities that like I'm not a part of. So if I'm interested in, you know, any of the communities you're speaking about, what's the best way to approach it so that they don't, I mean, because it's authentically wanting to help, but at the same time, not assuming that they can't help themselves, if that makes sense. But what's the best suggestions you would have in terms of really wanting to partner with people who you don't have the same experience?
Yeah, and before she answers, you just asked the pre-planted question in case there was, which was, I focus on the preposition for and with, which is often we do things for communities, which is not the right approach. How do we do things with communities? And it's an excellent question that I think all three can speak to.
I think there's a lot of kind of entry points into that question, which is a great question. So to me, like the ideal way to approach this is to build relationships, right? That it's all about the relational. And so there are communities in which I identify as a part of the community, like the disability community. There's communities where I am an ally, kind of regardless of that. Even the disability community, there's so many communities in which I don't personally experience that form of disability. And so for me, like any partnership is based on kind of what anthropologists would call deep hanging out, right? Like I just spent a lot of time in those communities and getting to know the people. And it's about showing up for the events that they have organized. It's about just spending time, right, after work, just being there and having conversations, because building trust to me is like the first step about any meaningful partnership. And so entering that and just saying, oh, I have this idea, can you be a part of this? Also, right, you've already constrained what problem you're focusing on. You've already constrained your solution space often, right? If you have a specific skill set methodologically, which we all often do. And so to me, having those conversations is so essential to building trust, because then you're formulating the problem together. What problem actually matters to that community, right? And how might you not just enter with your own skill set, but bring all the other resources that you have as, right, someone who's positioned in a specific company or in a specific network to that problem. So maybe part of it, I think, is, relates to our incentive structures, that we come in because we have certain incentive structures. But to me, an ideal community process is about being there and facilitating conversation and saying, actually, maybe I'm not the perfect person for this problem, but I can bring these other resources, right, and continue to engage. Which often means, like, as an academic, right, I was given advice early on that you'll have to do the work to get you tenure, and then you'll do the work that you think is really meaningful, which will take many, many years to show up that in a way that's legible to the university. And that's like the many years of just spending time in communities.
So I think, Rupa, you sort of said most of what I was going to say, but I can just add one of the ways in which we have done this work is really bringing our authentic selves to those conversations and to the communities. So it is really relational, but it's relational so that when you show up as your authentic self, you are allowing another person to bring their authentic self to the table. Trust building only happens when there's authenticity and transparency between people. And trust building is sort of the foundational piece of coming into these communities. The other thing I will say is we have a lot of resources on our website on sort of authentic community engagement. But engagement happens in a spectrum. So engagement is not just about going in, getting the data and getting the information that we need, but rather we try to operate on the other end of the spectrum, which is involvement. So engaging community members to give us the data, collect the data, be part of the sort of research process, and be actually engaged as researchers on the ground, to be able to share those experiences from their lived experience lens, right? That is another way of really coming in and working with the community rather than for the community. And then lastly, I'll say, in terms of incentivizing, I love that Rupa brought that up, because I think one of the ways that we show up in those spaces, especially when we're engaging a diverse set of communities, is to show up with sort of meeting the needs of the communities that we want to engage or that we want to engage with. So for example, I worked on a health impact assessment in a public housing redevelopment that was predominantly Hispanic, and we brought food because we know that food is a celebrated part of that culture. We brought food that was made by one of the community members so that it's authentic food to them. And then we had, a play space for kids. We had music. We had all these other ways in which we were striving to be meeting the community where they are, have childcare at community engagement meetings. I know this seems so obvious, but it is these little things that matter to the people that we want to engage with. So we're serving them as much as they are serving us.
The only thing I would say absolutely what my two colleagues have said here, but I would also sort of say is that one of the things, especially in Indian country, is I first did projects with folks that I knew, and then people called and said, could you bring your students to do this with us? Or they would call up and say, we were wondering, we don't think you could come all the way out here, but do you think you could put us in contact with somebody else who could help do that? And so part of it too is that by doing trust with people, you build up a kind of reputation where folks know that they can count on you doing the right thing. And I'm going to say something about incentivizing. I think maybe because I came into academics from practice, I always thought, fine, if you guys don't see the value to what I'm doing, I don't care, I'll go back to practice, which was a really good attitude, P.S. and by the way. The other thing that helped with that is that when I would do something with Native communities, they were really good about writing to the university. And they would say, we were so glad and your students are so nice and blah, blah, blah. And, I hate to say it, but I think that might have had more impact than a peer-reviewed journal. With the big university, I have to say that many of my colleagues and many chairs over time also couldn't refer to what I do as, oh, Lynn's doing some of that Indian stuff, which is really annoying. But it's also sort of like, well, wherever you are, you just where you are. I can't like proselytize you into understanding, but you just go with it. But I really think it is about sort of, if you are listening and if you see yourself as not the expert, but somebody who's just helping, coordinate the experience of everybody, it's good.
We have one final question. Do you mind moving over just so they can see you?
As everyone else said, thank you so much. Thank you so much for your presentations. It was really wonderful.
Yeah, if the light's on, it's on. You just need to move it.
Oh, I'm supposed to keep it that way. All right.
Yeah.
Is that better? Thank you again for your presentations. So this whole tenure process is an interesting process, right? So I'm an assistant professor, and recently I actually started collaborating with a nonprofit organization in San Antonio. That's where I am. That is called Disability SA. So we collected data on what some of the challenges are that people with disability deal with on day-to-day basis. We had a presentation here. I brought that into studio, and my students designed for this community, with the community. We had a lot of different panel discussions of people who do this on day-to-day, live with lived experiences, right? And then we had a presentation at AIA for the community. It was packed a lot more than we were expecting. And then we're going to publish a journal article, right? So that's all for the tenure process. I think I get all the benefits. What does the community get? So how do I go, past that? Because I feel like up until now, it's all been for me. yes, it's been with them, but nothing really for them. So any suggestions that you guys have, I appreciate.
So I think the first thing that comes to my mind is, have you asked the community what it's done for them? And I think I say that not flippantly. I say that because so in a health impact assessment process, we have 7 steps. We're collecting baseline data. We're going into communities and doing primary data collection. We're, all of this process. We're creating these recommendations. At every step of the way, you go back to the community. Because if we really have to achieve health equity or equity in any form, going back and asking the community, how has it benefited them? What is it that they see as beneficial and what is not, is really critical in order to serve the community that we're trying to do this for. But having them along that journey is really the sort of critical piece of understanding, is this actually making a change? Is this actually, as Rula said earlier, moving the needle? Or is this really just something that is extractive and benefiting us as researchers or scholars? So having them along that journey is the way to do it. And I would say, asking the community is the first step and should also be the last step of where we end.
I also think it's about being really clear about what you can do for whatever community you're working with, because a lot of times when I'm doing something with students, you have some things you need to do and you have some time things. And I don't want to raise hopes that are not possible to meet. So we are very clear with folks about what we can do and what, like we always say, no, we're not going to give you a set of building working drawings. So let's all just take a deep breath and know that's not what we're doing. But the other thing is that there's also these funny little things that you do that turn out to be an outcome you never imagined. When I took kids to the Coeur d'Alene at one point, they did something. This was to teach the students something. They were showing them a traditional weaving method. And one of the students happened to have a little iMac camera thing and sort of videotaped the whole process. And then when he came back, the students were like, oh, this is great. We should make a video. And I said, well, we'll call and talk to them, but if it can help them. And they have this young group that does exercise that's called exercise to powwow music. And the girls in that group sent the students music to play in the video. And then we sent the video to the weaving teacher because they were always looking for funding. So she now uses that video to get more funding to teach weaving in the community. And it was like totally like sort of accidental at some level. So, there are some things like that. And I would also sort of say the other thing about tenure is, to any of you guys who are assistant professors out there and doing stuff like this, when you put your list together of who they should talk to, you make sure that people like us are on that list, because we will stress the quality of the work you're doing and its importance.
Yeah, and I just want to add to that, Lynn, there are some universities that have community service as one of their tenure metrics. So even if you're not at that university, make sure professors from a university like that, Portland State University is one of them, are on your list, because then that is something that is part of their tenure process.
I'll just echo, what was said, but add one thing. And one is, we've talked about kind of this idea of entering conversations with authenticity. And I think what you just said was really authentic and vulnerable. And I think going to the community and saying exactly that I want to make sure that this isn't extractive, that I want to recognize that, maybe this was more beneficial for me, and what would the next step look like? What other things are you thinking about? And whether you can, support that, or you can use your network to find support for that, right, is kind of a way to, right, increase the trust and, right, the authenticity in that relationship. And then the other thing I would say is, right, even in creating academic products, right, who are the authors, right? Are those community members authors on the publications and the presentations? Because people who are also building their own careers and credibility and what their next step is. So for me, that's always a really important thing, is inviting community members, right, your community partners to be authors on those products as well. And it increases the quality of the product, but it also, right, recognizes all the forms of expertise that went into that work.
Thanks. So to close out this plenary, I invite Sharman to come up and say a few things. Hey, and Megan, can you get the slide? Thank you so much.
Hello, everyone. Good morning. Thank you so much. It was a fantastic and excellent presentation. We would definitely like to hear more next year in Mexico.
Well, I think we should probably just welcome Rupa, Lynn, Mimi for reminding us and keeping us accountable to what we say, to equity, and I think EDRA needs to be accountable. We try, but this is you left us with some really interesting and good homework for us to do. So thank you so much. I really appreciate it. Thanks.
In the closing remark, I definitely like to thank the conference organizer, the entire Clemson team, all the student volunteers. One more time, give a big shot. Lynn, who is the chair-elect, who is going to be the chair of EDRA board next year. She's not with us. She's in Canada and COVID-19. That reason she's not here. So I definitely like to extend a thank for her. Thank you. So there are a couple of things. We have a members meeting, which is going to start from 11:45. We have some important strategies and issues we like to share with our members. Please join us in that members meeting. And we are EDRA as an organization. We are trying our best. We're looking for more and more volunteers to serve the board or serve any committee or subcommittee or then any award programs. So please communicate with the headquarters, or you can email me or any other board members if you want to serve EDRA. Next year, the knowledge network, we're trying to make our knowledge network more and more stronger. So if you want to serve as a network chair, any knowledge network you are interested in, and if they don't have any chair or they have one chair, now we're thinking to go for chair and 2 more co-chairs for knowledge network. So if you want to serve as a co-chair, please let us know. That would be really helpful. Thank you so much. I'd like to end my the conference here. Thank you so much for joining us in person. Hopefully next year we'll be joining again in person in Mexico City. Thank you.